Sir.
Welcome, sir.
Anjali, Balamurugan, Partha, how are you?
Hello,
All
hello.
you
Good
are
evening.
in India
Hello,
or
sir.
even still UK?
Still
I'm
here,
still
sir.
in UK, sir. Yeah.
UK. Fine.
Both of them are still in UK, sir. Partha is also
We,
there
we
and
met
Bala is
them.
also.
We
So
met
they
them
all
at
will
the
be. Yeah.
RCD IIGS conference in
That's
Edinburgh.
right. We are coming to
Indo-UK Surgicon.
now Derby. Derby will be coming in November after WCS. In
Okay, great, sir.
yeah,
We'll meet
Association
you.
of yeah.
ALSGBA.
Yeah, ALSGPA, I think in 7th and 8th of November.
Okay.
Derby. Selva Segar, our close friend, he is going to be the incoming president. He invited us. So most likely I'll be going. It's just 2 weeks after our WCS. I'm sure we'll be meeting there. That's a big show. TUGSS has been given, I think it's a slot, isn't it? 3 hours or the session has been allotted. That's
Yes,
going to be
sir.
a show. That's
Yeah.
okay.
So it's going to be like the first on-site sort of a TUGS committee also. Dr. Arda has also joined us from Istanbul.
Hello.
Welcome, Dr. Arda.
How are you?
I'm
Hello.
good. Thank you for joining us.
Thank
Thank
you
you for
very
joining.
much.
Pleasure. Pleasure.
We are roasting
So-
here, I think in south, we are now reaching to 40, 41 degrees centigrade now. It's very hot in southern India. I don't know about Istanbul or either in UK. I'm sure it's a pleasant spring weather.
Yeah.
It is the same in Istanbul, so hot now.
Is it? All right.
So here in Delhi, we have crossed half century, sir.
Yeah,
We are
Delhi, I
consistently
think-
above 50.
Oh
my God.
Yeah. Very. There's an acute crisis of the load shedding and everything is going on here, even in the metro
Also,
cities. That's the
is water scarcity a real problem? We see some news. Is it?
horrible, sir. Horrible. People are surviving on water tanker supplies, basically. It's pretty bad. It's pretty bad right now. But I guess the good news is that they predict that the monsoon is hitting us earlier this year.
Also, it's going to be
That-
better than
that
the
could
last
probably
2
be a-
years.
Yeah.
Hopefully it will be next 2-3 weeks.
Yeah. Okay. So would you like to run your PPT? I'll just make you a co-host in just
Yeah.
1 second. Please go ahead, sir.
You are able to see my slides, okay?
Not yet, sir.
Yeah.
Yes, we
Yeah.
can see now.
Are you able to see?
Yes, sir.
We can see.
You can see me too?
Yes.
So I think, Dr. Parth, shall we begin? I think it's time. Okay.
Yes.
And Dr. Bala will switch on the recording, right?
Record. Yeah.
Okay. Let's start then.
Yeah.
Very good evening to all of you. I am delighted to welcome you to this highly anticipated webinar on stenting in GI endoscopy. Now, this session brings together leading experts and practitioners from across the globe to explore the latest advancements, techniques, and clinical outcomes in the field of GI stenting. Now, as the landscape of GI endoscopy continues to evolve, stenting has emerged as a pivotal technique, offering newer solutions and hopes for patients with complex diseases. Today's webinar aims to provide a comprehensive overview of this cutting edge practice, highlighting its transformative impact on patient care. Our distinguished panel of experts will share their invaluable insights and experiences, covering a range of topics, including the indications for stenting, technical considerations, various complications and their managements, as well as the future direction of GI endoscopy. So, whether you are a seasoned professional or new to this field, I believe that this session will enrich your understanding and inspire your practice. So, as always, after the guest speaker's lecture, we are going to open the house for panel discussion and Q&A session. So I would encourage you to participate by posting your questions, queries, and comments in the chat box, and we'll put them forwards on your behalf to our team of panelists. So to set the ball rolling, I would now request my co-host, Dr. Parth, to kindly introduce the chairpersons for the session. Dr. Parth, over to you.
Yeah. Thank you. So for this 16th session, we were pleased to have three of the esteemed panelists. We are happy to invite Dr. Arda Isik, who is an associate professor at the Division of General Surgery and School of Medicine, Istanbul Medeniyet University at Istanbul. I've had the pleasure to work with him during the TUGSS early surgical training chapter as well. And it's a pleasure to have you, Dr. Arda. Next, I would like to invite Dr. Anjali Davle ma'am. She is a consultant surgeon and a senior endoscopist working at Davle Hospital in Nanded, and she's been training many young surgeons in the field of endoscopy as well. It's an honor to have you, ma'am. Uh, the third panelist for today is Dr. Kelvin Woon. Unfortunately, he hasn't joined us today, but if he gets time, he will. He's a consultant general and upper gastrointestinal and bariatric surgeon at the Sunway Medical Center in Malaysia. Over to Dr. Balla to introduce the speaker.
Thank you, Parth. Thank you. So it's an absolute pleasure now for me to introduce the guest speaker for the day, who is none other than Dr. Iswamurthy. Dr. Iswamurthy is a distinguished surgeon and endoscopist with an illustrious career spanning several decades. He has made significant contributions to surgical education and professional development. Being a triple FRCS himself, he also serves as an examiner for the MRCS Board of Edinburgh and is an active member of several medical associations, including the IMA, the IAGS, AMASI, the Endoscopic and Laparoscopic Surgeons of Asia, and the Society of Gastrointestinal Endoscopy of India. Dr. Iswamurthy is a prolific author, having written 3 authoritative books on surgeries, including the Handbook of Surgery, The Art and Science of Endoscopy, and Surgical Pearls. He holds editorial roles as the sectional editor of the Comprehensive Textbook of Laparoscopy published by IAGS and the Journal of Minimal Access Surgery Endoscopy section. As a passionate educator, Dr. Iswamurthy has trained over 1,000 surgeons in the art of endoscopy through various courses across India. He is also the immediate past president of IAGS and the past chairman of the ASI Tamil Nadu and Pondicherry chapter. Currently, Sir is serving as a consultant surgeon and surgical gastroenterologist at Lotus Hospital in Erode and continues to advance surgical practices and mentor the next generation of surgeons. It's a pleasure to have you with us here today, sir. Thank you so much for joining. And the screen is yours. I would now request you to start your presentation. Dr. Iswamurthy.
Thank you, Pavnit, and thank you, team TUGSS, and all my friends across the globe, my dear viewers, my dear panelists from across the country, from UK, Istanbul, various countries. It's always a day on a nice Sunday afternoon from India. I'm just going to share what, as a surgeon's perspective, the role of stenting in GI endoscopy. I hope you're able to see my slides okay. My network is a little disturbed because of the windy weather just outside. I hope if there's any disturbances, let me know. Let me just proceed with telling. I'm just going to have these three learning objectives. First, I'm going to give an overview or basics of gastrointestinal stents, then a clinical case-based discussion on foregut stents, hepatopancreaticobiliary stents, and colonic stents, and the complications where and when it's required any emphasis. Then I'll give some current guidelines and what are the future prospects regarding the stent design and developments. Coming to the basics of the stent, there are basically, as we all know, there are three different types of the stents. Vast majority of them are self-expanding metal stents, even though we have also a plastic stent, polyplug stent made up of polyester, and also now biodegradable stent, polydiaxanone from Czech Republic, what is called ELA stents. But most of us, I am sure 98% of the time will be using only the metal stent, that also mainly nitinol. Nitinol by the name Niti, that is nickel and titanium from the Naval Observatory Laboratory from USA, that has developed this unique metal which has what we call the metal memory or a safe memory. Companies like Boston Scientific, they brought out ultraflex and wall stents. Cook Medical, what we call evolution stent, and Town Medical, that is Niti stent. So these are the three different companies we normally have. And let me just tell some qualities of an ideal stent. As I said earlier, the very important first quality is its self-expanding nature. When we take this stent or release it from its sheath, it just springs back to its shape and also size, what I call a metal memory. That is a unique property. And also it will have sufficient radial force to keep the lumen. So these are the two important qualities. So it can be used in any esophageal or pyloric, duodenal, colonic, or biliary, or even pancreatic strictures. Next important thing is about the nature of the stent. First, we came out with what I call an uncovered stent. The problem with the uncovered stent, probably we can all assume, because of its nature, it allows the tumor to grow inside. The tumor ingrowth has been a problem. To avoid that, we have two solutions. Either you go for what I call a fully covered stent from one end to the other end, but that makes it very slippery. So even though the tumor ingrowth may not happen, there is a high likelihood of migration. So with the uncovered has its problem of migration, nullified, but still there is tumor ingrowth, and is fully covered has the other problem. We come out with what I call a partially covered stent, which is covered in the center with the uncovered bare ends like a flange and a funnel shaped. So the design, the configuration, and the extent of the covering, it ensures that you have the best of the both worlds. So this is what the commonly used stent is, the partially covered stent with the bare ends and flange. Coming to the deployment mechanism, because this is something which we need to realize, it could be released by what I call a hand release or a pistol release. See, for example, the evolution stent by this Cook, it has something like a pistol grip so that you can just keep putting it like a pistol, and there is always what we call a point of no return. But till the time you can just go, and if you are not happy, then you can go back again. You bring the stent back into the sheath, adjust the exact location, and start deploying one more time. Other way which we commonly do, which is a little cheaper, is what we call a hand release. When I say it's a hand release, the very important thing we need to, if you are doing or if you're teaching your assistant to do, he has to have his dominant right hand passive. That is a little difficult for you to do. So he has to keep his right hand adducted, keep it still, and concentrate on his left hand, he need to pull back. Pull back, don't push forward. So this is what something we need to learn. Initial few centimeter may be little force you have to use, then slowly it will sheath. And before we do this, we flush the whole sheath assembly in the sideboard with some saline. Make it something like a lubrication so that the hand release is making a little easier. So these are the two types of release, and there are two types of stent deployment. One, of course, is through the colonoscopy, TTS. That is only for uncovered stent or a colonic stent or a side being scope, duodenoscopy. For esophageal stent, by far, they are over the guide wire and CM control. When we do under CM control, one of the important quality one has to look for is a fluoroscopic visibility, because it has to be precisely deployed exactly where the tumor, so that the obstruction is relieved. Not only we have a technical success, that should be a clinical success. So the patient dysphagia relieves. So we need to go with the stent assembly. And as I said earlier, we need to pull back. When you pull back, it springs open the stent as it's shown here. And when you see this, and you can see in the insert below, that you will be able to see the markers nicely where exactly, and you will be able to see also if it is going to be, for example, duodenal stent also, you can see nicely, you can see. So it should be having a good visibility, especially the markers. But we need to also realize one other, I would say it is a side effect, is the quality is a foreshortening. So because it shortens, we always aim for what I call a 2 centimeter extra length on either side. See, for example, if you have an esophageal tumor, which is 10 centimeter, ideally you should go for something like a 10 plus 2 plus 2, 14 centimeter length of stent has to be deployed. So there is a 2 centimeter on either side to ensure you properly deploy. There's a less likelihood of tumor overgrowth. So this is what another important thing we need to see when you choose for the size of the stent. Let us come to some clinical scenario as far as the foregut stents are concerned. The commonest situation where we'll be using a stent is, of course, an inoperable CA esophagus. Palliation of dysphagia in inoperable cases, for example, it could be also combined with brachytherapy also. Let me just go with this video.
Dear friends, welcome to the live endoscopy Lotus Hospital, Erode, Tamil Nadu. Right now, we have a case of an elderly lady with a dysphagia, and previous endoscopy showed she had a mid and upper esophageal cancer, and that was found to be inoperable. So we thought we'll bring her for further examination to see where exactly the lesion, whether the patient is suitable for dilatation and stent deployment. From the previous report, we know that is from 20 centimeter to 28 centimeter with a small risk or possibility of tracheoesophageal fistula, because the oncologist has seen and advised for a SEM stenting. So right now I have my own team. The patient is under general anesthesia with a tube in place, and I'm going to show you initially how I'm going to dilate and then proceed. So here is a flexi tip metallic guide wire I'm showing here, and this will pass through the access channel. It will find its way across the stricture area, and once we know that it is crossed this stricture, then I'll use the various sizes of the Savory Gillard dilator, which is quite a durable one. As you can see, these are all given by father and grandfather, and which is go through a small channel in the middle, and it is can be seen in the C-arm. As you can see, it is very durable and user-friendly dilator. It is usually the diameter of which we go is around 10 millimeter before we put the stent. We should not over dilate all these things. The diameter is actually the size of the Savory, which is shown as a number. So the diameter of the savary, like if it is say savary 10, that means it is 10 millimeter in diameter. Once we have that, in case there is some issue with savary, then there is another option, that is what we use, a CRE balloon, controlled radial expansion balloon, which will go through the access channel, and this, when it goes inside the 2.8 millimeter access and it will go inside the stricture, then we'll attach this balloon to a transducer, a pressure transducer device or a syringe-like device, or what I call the inflation device with a pistol grip. And I'll request my staff nurse to hold it and forward button, and she presses, and when it's in the right middle of the stricture, what will happen is, as we push more and more saline, as you can see, the balloon inflate to the predetermined diameter. Usually this one is a 10, 12, 15, and the pressure, it will be shown in the pressure transducer as shown here. And that will, once it deflated, we'll take this balloon, then that will let me to pass the guide wire and then deploy the stent. So these are the two types of dilators we use. One savary, most common one we use, and this, the second one, occasionally we use, but this is quite an expensive way of trying to dilate. So let's go to the patient and see whether we can demonstrate deployment of self-expanding metal stent. Before that, we need to do what I call a diagnostic endoscopy to look at the length, and we have to make a mark of the upper, lower level of this lesion with what I call an external marker. And once we put that marker and once we measure, then there are various sizes available. We usually put what we call a +2 on either side. If it is a 10 centimeter, then we have to put 2 centimeter on either side, so that there is no risk of what I call a tumor overgrowth. So that's the way we measure. So we presume this patient had a 10 centimeter lesion, so he would require possibly a 15 centimeter stent, and this is one of the such stent, what we call, by thanks to the Shally, and this is what we call a distal release system. And once it is going to be demonstrated, I'll exactly tell how it is going to release and how it is going to be deployed under C-arm control. And let's go on to the procedure now. I'm just about to show you the lesion. As you can see in the endoscopy view, you can see a stricture at the top end. I am passing the guide wire just to go through this lesion. And if you have any difficulty passing, then you have to be very careful. Look at the C-arm, just to make sure it is going right in the midline and go down in. And once you are sure that it is inside, then you go for a dilatation. Start from always the smallest. And the rule of 3 is applicable only in corrosive strictures. Here, it is only pre-deployment of the stent, so we don't over dilate. I started with the 8, then going to the 10 millimeter diameter of this savary. And you have to see there are some tricks in our sleeves. One, there should not be any buckling in this particular spring. As you can see, it will buckle very easily. So with the twisting movements like this, I gradually go. Very good lubrication is the next important thing you need to ensure, and until it goes very close to the mouth, you just go for a gentle twisting movement. Once it's go inside, and there is a marker to say 10, 20, 30 and 40 centimeter from incisor tooth, and always you try to push it in by using your non-dominant left hand in a supinated way, and it is very close to your shoulder. So the pressure exerted is very minimum. Otherwise, if you use your dominant right hand or use it like this, like a chisel, then it will cause more damage. You will over dilate and cause perforation. So you can see me how gradually I'm going millimeter at a time, at the same time doing a screening whenever it is required. So ensure that it is in the right place. Then by railroading mechanism, what I call, as I pull back the dilator, I push the guide wire so that the guide wire is not coming out accidentally. So we should not lose. This is the another that is called any exchange. As you can see here, there is no shift of the guide wire. It is still in the midline, right in the place I wanted. Then once you have done this, then again you go back and place the guide wire with the endoscopy. Now the second stage, what I do is trying to do the marking, proximal, distal. As I said before, this patient is having a very awkward place, the tumor, so I need to be very careful of exact site. So this is what I call the proximal limit I'm using some safety pin as a proximal limit of the tumor that is around 20 centimeter in the incisor teeth, that is about 5 centimeter below the cricopharynx. So I'm just checking at the top end. Here is the top end we had. Then after the putting the safety pin, as you can see, it is matching. Then you go further in and then find the distal marker. You put the distal marker and again another marker. So staff is ready with that one, and the distance between these two is the length of the stent plus 2 centimeter on either side. So that is the total length of the stent you are going to ask for. And you can watch, I continue to do 2 more markings. So this is the length of the stricture, as you can see, the proximal and distal. I need 2 more markers. What are the 2 more markers? The one, of course, is the lower end of the esophagus, that is LES, I want to know, because I don't want the stent unnecessarily projecting into the stomach. So that's why I am putting a mark in the very lower end like this. So I don't want the stent go anywhere below this particular mark, that is the lower limit. Then the next more important thing of all this is the proximally I want to mark where the cricopharynx is, that is at 15 centimeter, because whatever you do, you should not come very close to the cricopharynx, like this top one. See, out of the 3, the topmost one is at the cricopharynx, and it should be well below that one. Now I am, which scale I am measuring, the length of the thing is around 10, so I am adding 2 on either side, 10 plus 2 plus 2, that is 14, so we chose a 15. So we gradually we remove this endoscopy, then we pass the stent assembly with a well lubricated assembly. Then we need to ensure that in the C-arm and it is in the right place. Then I just, as you can see, my left hand is actually doing all this work where right hand is adducted, kept still. So I am pulling back the outer sheath, which is very important. Don't push, pull back. That is a secret, and there should not be any jerks. Actually here there is a little bit of jerk like that because it was a little tight, but when you inject some saline inside in the side port, it should not be a problem. Then once you are deployed, make sure that you are able to remove that, the inner plastic one, then I am just taking the remaining assembly outside, and the stent is well deployed, and we are going to see it again by a fluoro. The whole procedure is done by intermittent fluoro. As you can see, it is between the top one is a cricopharynx. It is right at the upper end. So it is between the upper end and lower end. But I would prefer probably it is another 1 or 2 centimeter just above the second marker. But at the same time, it should not be very close to the first marker. That is a challenge. Can you readjust? That is a question. If after deployment, yes, it is possible, as it's shown here, you can go with a rat tooth or a biopsy forceps. There is usually a thread at the top end. You just gently pull the whole stent because it is just now deployed. Still, it can be micromanaged, the exact deployment. So I just pulled it a little bit, about a couple of centimeters, as you can see, and under the control of the C-arm. And now you see the C-arm now closely, and it is more or less like a optimum position, about 2 to 3 centimeter below this is the cricopharynx. And you can see the cricopharynx is about 3 centimeter below the cricopharynx. In the funnel-shaped proximal flange is well within or below the cricopharynx, ideal place, less chance of migration. So this is the ideal placement. At the same time, I just concentrated at the lower end also, just to ensure that it is within the esophagus, it not projecting beyond the lower esophageal sphincter. So that's what the next picture we need to show. So this is the picture number 1, as you can see just now you have seen, and we'll move on to the next picture, and that will exactly show where exactly the lower end. See, here is a final one, that is the lowermost pin at 6 o'clock position is LES. It is just above that. So it is also funnel shaped, nicely expanded, so nice deployment. So we were happy, but still you should not feed these patients at least for 24 to 48 hours for the stent to expand further. Thank you very much.
As I said from the video, you can clearly see the steps. Very important thing is marking, exact deployment. Always have the C-arm for your rescue. Just make sure the deployment is where you intended to do. And 24 to 48 hours later, when the patient is fed with the liquids, then you have to give him clear idea about what all the liquidized diet he can have, what sort of effervescent drinks he should have after that, and what he should not do's and don'ts. Otherwise, stent blockage with the unwanted intake of food is going to be a problem which we need to avoid. Coming to some challenging situation, here is one challenging situation sometimes you may have, that is tumor high up. See, for example, around 20 centimeter, that will be too close to your comfort, cervical esophageal stricture. There, the option is we have what we call a proximal release system stents, like an ultraflux is available, or ponio stent or a low profile stents, where this is just about a centimeter in length. So this is also possible. So, for example, as this depicts two different types of stents, a distal release, which we commonly use with the ball stent and the distal release. This is what we use, but there is a proximal release system is also available, and there it opens from top to bottom. So that will be the ideal one, especially when you have a cervical esophageal stricture. The next important thing is to measure the lower end, you need to take the scope below, but if the diameter is very tight, the scope cannot enter, then you may have to use either a Savory or a CRE balloon, as we did in this case. Because, but even when we do that, as I said earlier, we have to ensure you just confine yourself to not more than 10 millimeter diameter, because the scope is around 9.2. So you just enough to get the scope down to do all the measurement, or even you can go for a finer scopes, like for example 6 millimeter diameter pediatric or transnational endoscopy also you can take for the passage and measurement. Coming to the complications one foresee here, the earliest complication, as I said, is a stent migration. The last thing you want to see is you deploy a stent today only to see that it is migrated, it is already lying in the stomach like here. But sometimes if you have a lucky day, as you can see, most of the stents are with the lasso here at the top. So you may be still, with a bit of luck, able to bring it back, because as you pull it, it becomes a little narrower in diameter. You may be able to take the whole stent, not only through the esophagus, but also through the stricturous area, and deploy exactly where it has to be. And to prevent further migration, either we can put a couple of hemo clips there, or you can put a thread across and bring it back and attach it and stick it to the nose for a few days. So there are various ways one can retain the stent, prevent further migrations. So stent migration is a problem, especially when we use a fully covered stent, but it happens even in other stents also. Severe chest pain, we have seen chest pain is an issue. Perforation can happen, and also patient feels that uncomfortable chest or a throat discomfort, like a globus sensation all the time. And as I said earlier, tumor ingrowth, tumor overgrowth, or thorns in this case, and in the case of extensive tumor overgrowth, one may have to go back again, either pulverize those areas by APC or a laser, or you may have to put another stent inside. So there are various options available to nullify this. Coming to the less common problem one may have to foresee is a malignant gastric outlet obstruction who are not fit for surgery, like this CT image shows. We have three options: balloon dilatation, endo-ultrasound guided GJ, or more commonly the self-expanding metal stent, or of course a surgical bypass. Coming to the stenting as it is, whether to use uncovered stent or a covered stent, even though we use vast majority of them is an uncovered stent, still the issue is more common here, like a stent migration, tumor ingrowth. So one has to be very careful what to do, and you need to be highly case selective in these situations. The principle is essentially same. Only thing is the trick is to make sure you are able to take the guide wire across the C loop quite a long distance into the jejunum, so that you are able to deploy in the right place where you want it to. And when you do surgical bypass and when you do endoscopic stenting for gastric outlet obstruction, the question can be answered this way. If the patient has a little longevity, like for example, more than 6 months to live, probably you, and also his performance status is little better, you may consider surgical bypass over endoscopic stenting. And now the increasingly people are considering what we call endo ultrasound guided stents, the human opposing stents between the stomach and also the nearest jejunal lobes. And there are double balloon catheter technique wherein you are able to identify a loop of the proximal jejunum and are able to pass a guide wire across, and a single stage lamp stent deployment is eminently possible technique which has to be learned even by the surgeons with the increasing experience we are getting. So that will avoid surgical gastric bypass. Coming to the what is the role of stent in case of benign stricture esophagus, if you ask me, ideally one has to see whether it is something like an interactable benign stricture. See, for example, I am bringing the patient every 2 weekly. I've already done 5 sessions, still I'm not able to reach the satisfying diameter of around 14 millimeter. And you can use Savary, CRE balloon, or even if you can use a Kinacod injection to prevent further. In spite of all this, if patient has resistant to all your treatment, conservative treatment. And the other option we have is, of course, a stent placement. There are 3 different types of stents. Either you can consider a plastic stent or a fully covered self-expanding metal stent, or more recently, biodegradable stent. So these are all the 3 options for the benign esophageal strictures. And the fully covered self-expanding metal stents, in addition to the strictures, it is now getting used also in the anastomotic leak. Some of the perforations, either endoscopically induced perforations, and also some fistulas. But as I said earlier, if you have a fully covered stent, the main thing is the risk of migration. One has to have a way to avoid that by using a suture at the top or clip at the top. And also we need to ensure these patients are brought back after sufficient dilatation, at least about 8 to 12 weeks time to have the removal. If you leave the stent a bit longer than that, it is going to be increasingly difficult to remove the stents. Coming to the leaks, because the endoscopic rescue for a surgical complications, it could be either a esophageal gastrectomy for a cancer or it could be a bariatric surgery. See, for example, if there is a leak after a sleeve gastrectomy, we know that it is usually because of the increased pressure of the pylorus. The commonest site, of course, is the top end of your sleeve, right at the OG junction here. And if that is the case, and especially when it is going to be like presenting a little bit late, like intermediate and late, there you may have to consider a stent deployment, ideally something like a mega stent, a large stent, which is long enough to go not only from the esophagus right through the sleeve component of the stomach across onto the duodenum. So this is what, to avoid migration, now people are increasingly using something like a double pumpy stent, the beta stent, like a nitty stent. And there are additional management options available for anastomotic leaks when it comes to the bariatric, like dilatation or clip deployment or subclotomy or putting multiple stents into the cavity and draining them, or even endosponge. There are options, and each one, according to the institutions and the backup, they have to have their own way of doing as per the case warrants. Coming to the leaks after forehead surgeries, especially when you have total gastrectomy and esophageal jejunal anastomosis, and a few weeks, you may have to keep the patient on either a nitty beta stent or a Ella seal stent, and then you ensure by radiologically that it has healed completely, then you can remove the stent. And I request all our viewers to go and see this European Surgical Gastroenterology cascade of guidelines regarding the stent, where to use and what to use. When it comes to palliation of malignant dysphagia or malignant tracheoesophageal or bronchoesophageal fistula, I think there is a strong recommendation. But when it comes to the refractory benign esophageal stricture, yes, but the recommendation is weak. And when it comes to the leak and fistula, even though it is quite helpful, there is a secondary strong. What type of stent to be used, still there is a debate going on. But I think vast majority of them, if at all you're going to use a stent, is a fully covered stent. Coming to the briefly to the colonic stent, if you have a left-sided obstruction, then you may have to consider for various reasons. One, of course, acute malignant colonic obstructions as a bridge to surgery, so that instead of submitting the patient for a colostomy, then surgery, then reversal of colostomy, like a three-stage procedure, you may have to consider this as putting a stent, relieving the obstruction, 2 or 3 weeks later taking them for a laparoscopy or a laparotomy surgery. Second, of course, is a palliation, where obviously it is an ideal indication. Palliation for a colonic cancer or a extra colonic lesions, malignant lesions with the inoperability, one may have to consider. Like in esophagus, it could be a covered or uncovered stent. Most of the colonic stents are through the colonoscopy, that is a TTS type. So uncovered stents we use. But you have to vary of what we call the risk of perforation. Sometimes there will be a what I call a technical success, but a clinical success may not be there if you are not choosing the case appropriately. So one has to be very careful to measure the length of the stent and the stent completely deployed and then completely opened. Then only you will be able to until at least around 20 to 22 millimeter diameter. Then it will be effective. And sometimes when it's go for a the stent expansion, especially people on some sort of chemotherapy like anti-angiogenic drugs, there is been mentioned that there is an increasing risk of perforation. So this may be a relative contraindication for a colonic stenting. And like other cases, if you put a more distally the stent, like a rectosigmoid tumor, one of the worrying problem is a migration. Next, let's move on to finally to the hepatopancreaticobiliary stents. And I think this is a chapter by itself. We use stents either for a patient with a bile duct stones, biliary stricture benign and malignant, some leaks post lap coli, and also some challenging pancreatic disorders. When it comes to the types of stents as well as the biliary and pancreatic concern, one has to have all different sizes, lengths, and also the types of stents. See, for example, here I have shown a Amsterdam or a straight stent in the middle with the two flange, which is now in our department is less commonly used, because one of the issues with the stent is, of course, is the risk of stent migrating into the bile duct. Then it will be a nightmarish situation trying to retrieve it. So the option now we have is either a single pigtail stent or a double pigtail stent. We prefer mostly a single pigtail stent with a pigtail in the duodenum. Double pigtail in a very dilated system, where you can put this one so that avoid stent not only migrates inside, it will not also migrate outside into the gut. And normally, if it is only periambular problem, one can go with a 7 centimeter. If it is from the below the hepatic duct, 10 centimeter, and if it is a little higher up, one may have to go for a 12 or even rarely, very, very rarely 15 centimeter, but usually 12 will. So 10 or 7, one has to be very careful, and we always, bigger is better. Like if you have a therapeutic ERCP scope, one has to go for at least 10 French for having some 3 or 4 months of longevity. We use 7 French stent only if it is going to be few weeks, like a post CPD clearance for a CPD stone clearance. And there are ways of stent deployment system or release system. One has to teach the team so they really know exactly how the stent is deployed. And let me tell you, these are the, as I said earlier, the 3 common situations. Like if you remove not all stones, there are likelihood of slight residual stones after ERCP for a bile duct stone. Better put a stent and come out. Or if the patient has severe cholangitis with a stone, just put a stent. Don't think about removing or crushing the stone. So these are the two situations. Stent will be a rescue for you. The second common condition is a post-lap chole bile leaks, like for example, cystic duct leak. That situations, all you need to do is put a stent to bring down the intrabiliary pressure remarkably. Ensure that what the stent you deployed is a 10 French, it goes all the way above the cystic duct insertion, then it will have an adequate drainage, and within a day or two, the drain coming through the outside drain, I mean the bag, you can see it is dramatically reduced, then you can remove even the external drain. The third, of course, is the post-lap chole or other bile duct strictures, that you can use various techniques as shown here. You can put one stent and then two stent serially every couple of weeks. You can keep adding a stent in order to stretch and relieve the stricture. This is one of the technique, Costa Magna technique. And nowadays people go for a biliary stricture dilatation and putting a biodegradable stent also. Coming to the cystic duct stump leak, which is a very common thing, it is very, very gratifying procedure to do a sphincterotomy, then put a stent, 10 French stent, put all the way just above the where it's leaking. So that way, dramatic improvement you can notice in a day or two. There are a couple of tips I wanted to give you regarding the stent deployment. Of course, is choosing the type of the stent. Go for the right size, preferably single pigtail in these situations. Keep the scope very close, and it should be below, so that when you push the stent, it should go upwards. And there are various ways you can ensure by using the elevator down the store. I mean, the stent goes up, and also by using your body movement turning to the right or a right torque. So these are the ways you drive the stent into the duct. Because one of the important thing is if you are not too close to the ampulla, sometimes the stent will buckle and you will fail in deploying the stent the intended place. So that's all I wanted to tell regarding the plastic stent. When it comes to the metal stent, self-expanding metal stent, it has a very important role, especially for managing various malignant strictures, especially if they become inoperable and they are like any other areas. It can be fully covered or uncovered stent. And the deployment system is again, it is going to be released by pullback mechanism. And the philosophy of stent deployment is when you have a non-resectable malignant biliary obstruction, if the probability of survival of the patient is shorter, like less than 4 months, preferable you go and limit yourself for with plastic stent like 10 French. But if he is going to survive longer, it is better to give the patient the benefit of doubt and the self-expanding metal stent. I think nowadays, having said that, most of the time we use self-expanding metal stent 10 centimeter or more. The resectable malignant biliary obstruction, will you put a stent preoperatively? This is often asked postgraduate question. I think the bottom line is we need to avoid any sort of prophylactic stent deployment, like in a periampullary or pancreatic cancer. However high the bilirubin level is, and prefer primary surgery. But there are three situations: either if the patient is having a severe cholangitis, or there's going to be some time involved before you do surgery, like planning for a neoadjuvant therapy, or if the patient is unwilling or unfit for surgery, then you may have to do. Otherwise, try to avoid contaminating these, usually a sterile, uninfected by biliary system by putting an unnecessary stent in this situation. When it is a hilar obstruction, whether you put a plastic or a metal, whether you put in one side or a bilateral stent, that needs a lot of evaluation by looking at the patient's MRCP and CT scan carefully, because there are some broad guidelines. We need to make sure we know the biliary liver anatomy and liver volume of the diseased side and undiseased uninvolved side. And we need to aim at least drain more than 50% of the liver volume to have some meaningful palliation. And PTC and PTPD may be used, especially if you are not able to succeed from below also. And if some stents are usually better, even though plastic stent, I said, if you are able to do this and then you can do away with the deployment once. By accident during ERCP, if you have injected a contrast and which unintentionally pacified upstream ducts, that has to be drained. So that is another important message one has to see. And the last word in my presentation regarding the role of pancreatic stent. Of course, one of the important area where we need to consider is to prevent post-ERCP pancreatitis, especially if repeatedly you are doing a pancreatic guide wire is going more than 3 or 4 times, or even injected the contrast, something like that. Then if the guide wire is still there, then it will steady the pancreatic system and you may have to still venture into the bile duct. Then you do a stent, or upfront you can do a stent. As you can see here, you can do a ERCP if you find that repeatedly you are going into the pancreatic duct. Then you leave the guide wire, put a 5 French stent. It not only ensures that you won't go into the pancreatic duct anymore, but also it prevents at least the incidence or the severity of post-ERCP pancreatitis. Once the stent is in place, all you need to do is either you do a needle knife sphincterotomy or by a bow wire, you go above and to the left, there is around 10 o'clock, and with a guide wire, flexi-tip guide wire, you can see, and hydrophilic guide wire, you'll be able to cannulate fairly easily once you have done that, and the rest of the job as it is. And the stent usually in the pancreatic system, it usually falls itself. And the other rare indication of stent is, of course, the minor papillotomy, minor duct papillotomy in a case of recurrent pancreatitis and pancreatic division. So, ladies and gentlemen, what are the futures we hold? As we know, there are increasing role for lamp stents in a pseudopancreatic cyst or an endoscopic US assisted GJ. We have already seen this has increasing role, and I'm sure this by further evolution in the design is going to be one of the simplest mechanism. Deployment mechanism already is very easy to deploy. And there are also going to be more developments in the anti-migratory stents, the way they design the outside with the double stenting, flare, hook deployment. Third, custom-made stent. Depending upon the patient's tortuous strictures, we can even design and develop a 3D printed stents. Finally, a drug-eluting stent. Taking the lessons from vascular stents, I think people are now designing with the stents impregnated with polytaxyl and also the gemcitabine, bifluorouracil. There are still trials going on. I'm sure that is the way forward to increase the local control, especially when it comes to the biliary pancreatic cancers. So I think there is a lot, and the least as a surgeon we can see is always same stent is always there as a surgeon's rescue. And one has to know various types of the stents, where and how to deploy, and learn from this very important additional, skill set one has to develop in their career. Thank you for the opportunity. Thank you, Pavnit, and all the chairpersons for the patient listening.
Thank you, sir. Thank you for that wonderful talk. I do realize that GI endoscopic stenting is in itself a very, very vast topic, but you have done absolute justice to it, and you have comprehensively covered all aspects, various indications, various scenarios of GI stenting. So I now open the house for discussion and invite our chairpersons for their comments and queries, and followed by some queries which have been posted by our attendees. We'll take them one by one. Dr. Arda, would you like to go ahead?
Yeah, thank you very much, Dr. Esfara Murthy. Thank you very much for this valuable presentation. I have a question. In your presentation, in one of slides, I saw the contraindication for neoadjuvant therapy, SEM stenting before neoadjuvant chemotherapy is contraindicated. Why is it contraindicated before neoadjuvant therapy?
In esophageal cancer,
Yes, in esophageal cancer, why is it contraindicated? May I learn?
I think there is always a risk when you give a neoadjuvant therapy, the tumor is going to shrink, and there is a high likelihood of stent migration. And of course, in a patient where you intend to treat them with a curative intent, I think the general wisdom is the stent will not be necessary. So we won't go for a stenting. That is the oncologist. That's what our team decides. Stent is mainly as far as esophagus is concerned with a palliative intent only. You can add on a brachytherapy if you want, an additional improve the patency and also durability of its effort. But in a patient who is having a curable, eminently curable lesion, or where you are going to use a chemotherapy, our practice is not to use a stent as a modality to
Thank
relief
you.
of dysphagia.
Thank you very much.
Okay, Dr. Anjali, would you like to come in before we take the questions from the attendees?
Yes, sir. Wonderful talk as usual, Ishwaramurthy sir. It's nice to listen every time. One thing I would like to know that as a beginner, if somebody wants to venture into these stent placements, and so what is the first line to start with? Like benign stricture, which is possible, that should be the beginning point, or how it should be, sir, uh, for the viewers who are listening, and for me too, who do not have much experience of the malignant stricture and dilatation. Benign is okay, polypectomy, snare polypectomy, but to venture into the colonic malignant obstructions, esophageal malignant obstructions, whether to go for a plastic deployable stent, whether to go for a metal deployment, how the curve should be, learning curve should be, sir.
In reality, when you have an inoperable mid-esophageal CAs, esophagus, I think that is the ideal one to go. I mean, even though, because benign actually, by paradox, it may be benign, but it's very, very tricky one to deal with. And one should not take the stent as an option there. It should be a last option, as I said, really, but it's intractable. You have to persevere with a serial dilatation. Of course, you need to motivate the patient, either with a Savary, if it is possible. Corrosive strictures, I think we do Savary strictures, but at one point you feel the patient is coming every 2 or 3 weekly, and still you are not able to make the patient eat comfortably. And can we consider something better? And so that's where you think of this option. So I consider first simple dilatation, then dilatation with injection of steroid like echinocort. In spite of that, it fails, then I discuss with the patient or relatives regarding this option of fully covered stent. So this is the option which has been used only more recently, I would say. But if you say, for example, I have 100 cases of benign stricture, how many cases do you consider? Maybe 1 or 2 only, because it's a very small percentage we are talking about in the real practice. But when it comes to the malignancy, that's where most of you can do a gratifying, because everybody left the hope, and the patient is either coughing every time they take a trickle of water, and like they have already have or about to develop a tracheoesophageal fistula, there you can give some reasonable palliation, at least for a few weeks. That is where the ideal indication. And that's where even if you commit some mistakes, patients, you are doing with a good intention. So that is the ideal one to choose for. Don't choose have a benign condition, make it a more virulent one. Have something more serious one where you can make a meaningful improvement. So mid-esophageal stricture is one to go for, straight one. And only thing is you have to have either one of your senior or one of the colleague who knows the deployment mechanism, because otherwise the principal steps are essentially same, and all you need is even the people say you can do even without CM, but I will advise not to go because even though there are measurements you can do endoscopic inspected deployment. There are various shortcuts are available, but I think one has to learn the proper technique, and the technique is CM is there. External marker is easy to deploy. Okay, and so that and provided the patient is not moving in the table, have the anesthetic on the top, you have one problem less to care about because airway is an issue you need to see. And most of the time, this esophageal dilatation is done with the patient in a supine position in our setup, and with only the head is turned to you, because then you will be able to see the anatomy clearly. Left lateral is okay for conventional therapy, but when you do a deployment of stent, so there it will be little tricky for a beginner. So one has to learn all these techniques. So that's why I always teach my youngsters, even in an elective situation, try to do few endoscopy in a supine position, because you may be called to do an endoscopy in a theater when a patient, like when they go for a fundoplication or a lap LS, there you need to know when a patient has supine position. So this is one such situation, doing dilatation or a deployment in a supine position.
Sir, as you said that in the corrosive stricture, so with your experience, sir, does the corrosive stricture have a uniform stricture? Because before venturing into the corrosive stricture management, do you advocate some invasive investigations like CT so that to know whether it is a uniform stricture or a segmental stricture where the chances of perforation are much more and where they are less? So how to go with?
I mean, immediate few days of any corrosive CT is in our algorithm. But as a stricture, when it develops stricture, barium swallow is the ideal one. If you have a barium swallow, it puts a clear roadmap whether the stricture is a short straight stricture or the multiple strictures or a tortuous stricture or a stricture with a pseudo diverticulum at the top. Because the problem is a stricture with a pseudo diverticulum at the top because of the higher pressure. And when you go blindly, there's every chance you may go into the diverticulum, cause trouble. And once you know the anatomy, the next time it will be easy. Actually, the first dilatation I always recommend, or first or second dilatation with the CM. But the next subsequent dilatation, you and your patients, they know exactly what's going to happen. And we can do it as an outpatient setting also, especially the mid-esophageal stricture. Only if it is the lower end, you should be much more careful because the perforation is more likely. And upper one third, because of the airway issue, you need to be careful that you have an airway under control or anesthetic standby. So otherwise, mid-esophageal, tortuous strictures or multiple strictures, you can, if your guide wire, a flexi tip guide wire or a stiff, super stiff hydrophilic, I mean the zebra guide wire, either of them you need to use. You always err on the lower side, the principle. If you think the patient needs 12, you can even stop with the 10. A patient not able to drink water is better rather than trying to do something more than get into trouble. And always you watch the patient's pulse rate and always have a habit of feeling the patient neck and chest for any crepitus, especially during the procedure, post-procedure. Persisting pain, I mean the having palpable crepitus on the neck and chest, and also tachycardia. If they are present, they warrants the patient has to be admitted. The patient has to have further imaging done. And in our, even if you have done a little like a post-procedural perforation, eminently managed by conservative therapy. When you diagnose early, admit the patient, and usually they do a pill with nil oral parenteral antibiotics and IV pantoprazole, and you can, if they're nutritionally okay, they can manage, especially the upper esophagus. They conservatively they manage very well.
One more, sir. As you mentioned about the cystogastrostomy, that in the pancreatic pseudocyst. In such cases, what is the preferred mode of the stent which is used, sir? Whether it is a both-sided pigtail or it is a one-sided pigtail, which is the preferred mode of stent in the cystogastrostomy?
A cystogastrostomy, I mean, as far as the pancreatic fluid collection, now it is getting more and more input. I mean, the way we manage, I think 10 years ago is changed from what we are doing it now. So very important thing is you have all the imaging possible, you know, what is the content like. Is it going to be a clear fluid or it's going to be, I mean, the lot of necrotic material is going to be there. Depending on ideal stent, it has to be endoscopy, endo ultrasound guided, number one. Second, you should have an experienced US specialist to do this. It can't be just done with a conventional side view endoscopy, because you see a bulge on the posterior wall of the stomach doesn't mean you can just go and prick it. So one has to be very careful. It should be US guided. Lamp stenting is ideal.
Mute from your side.
Because the small plastic stents, when you put, it will never do the job which it intended to. It may drain clear fluid for a couple of days, but usually get blocked when you have a lot of problem. I mean, you make a two-way traffic, you make the cyst more infected subsequently.
Okay,
Right.
thank you.
Right. So I'll just take a couple of questions which have been posted in our chat box. So this is a question which is from Dr. Roop Jyoti. He's talking about a case of a young child of around 5 years in which the patient presented with a foreign body impacted, followed by a distal esophageal stricture which was dilated by balloons. So 1 month after the dilatation, the patient represents with the same complaints and the same stricture. What should be the next course of action, and is there any role of stenting? And if Kenacort is to be injected, he wants to know how and what should be the dose of Kenacort.
I don't
Dr.
have personally
Ishamurthy.
the practice, I mean, my experience with the stenting, but I would think probably in this age group, I want to know whether the child had any surgery like esophageal anesthesia or any procedure, or it is stricture, whether it's a corrosive injection, what is the cause for the stricture, anastomotic stricture, or is it disease? Whatever it is, at the end of the day, they usually respond very well with a simple dilatation, either with the CRE balloon to start with around 8 to 10 millimeters. Slowly you go every 2 or 3 weekly under anesthesia or savory. And yes, we can use, if 5 attempts have been done and it hasn't responded, then it becomes intractable. Definitely, Kenacort has a role to play, and we have seen it. And it seems to be at least 1 or 2 sessions will definitely make an improvement. Stent in this situation, I think, is more theoretical. I won't try in a child of this age. That's the way I see it.
Right. Thank you, sir. Thank you. Dr. Ricardo wants to know, sir, are this the pigtail stents available for any chronic leaks? He's basically trying to understand what kind of a stent should we use or endotherapy should be used for chronic leaks.
Any anastomotic leaks, when we put the nightmare is stent getting into that abscess cavity. So that's why it's always a double pigtail stent. So the ideal is a double pigtail stent, and the size which we can deploy normally is around 10 French only. So that is what you go. And more the better, more the merrier we call. So two, if it is there, it's not only the drainage is through the stent, it is also along the stent also. So that's why most of the biliary stents we know by experience, most of the time the drainage is more along the stents. So that's the way it
Along
is.
the stents. Exactly. Thank you, sir. So I just have one more query, sir, because there are a lot of youngsters who are planning to now start GI endoscopy. Post esophageal stenting, what would you advise should be the regimen for starting the oral intake for that patient, sir? How often and when to start?
I usually a little bit conservative, even though people they give straight away. 24 hours I wait, because most of the metal stents they go for a dilatation to its predetermined diameter within few hours. There is no need for a balloon dilatation. If it's a biodegradable stent, LR stent, after deployment, you need to actually dilate it to make sure it stays there where it is intended. Whereas the metal stents, you just deploy. Main important thing is try not to go through the stent. Try to see whether you have gone. So only the upper end you see. Verify with a check endoscopy. The check endoscopy after stent deployment is seen only to make sure where is exactly, whether it's above the tumor. Because you presume it has crossed the tumor and also opened up below only by a Sion. Try to do there and then you push the stent unnecessarily by lateral force. So try not to do that mistake. Post-operatively, 24 hours later, you give them a clear water or a tender coconut. That's what I do. And if they swallow, that is enough. There is no need for a routine X-rays. Unless the patient has a pain, then there is a chest X-ray you can do just to verify there is no problem. But very often you don't see stents in the X-rays. Take it from me. But still, for our own satisfaction, one can do a chest X-ray. And liquidized diet, you need to involve a dietitian, written information regarding what to eat. Nothing comes straight from the kitchen. It has to go into the liquidized diet. They have to take a spoon and they have to take it. It is like a sloppy diet. They may ask you, "Well, can I eat chapati?" or they can eat all this because, and always when they eat as a group, as a family, the temptation is try to eat it. The stent has no peristalsis. That has to be taught very clearly, however wide it is. So it will be the food bolus can get very easily stuck. So every time when the patient takes like a 200 ml of liquidized diet, it has to be followed by about 25 to 50 ml of effervescent drink. It could be a Sprite or 7-Up or whatever carbonated water they can have it. That will actually flush the stent, and they have to stay upright. That's my way. And or if their stent is crossing, for example, sometimes you put a stent right across the OG junction, there is no need for anti-reflux valve stents. We used to have that deployment done with a lot of extra expenses, but they are not really required. Even if the stent goes across the OG junction, the reflux back is not a problem, provided the patient is not taking food 2 hours before he goes to bed, or even if he goes to bed, he goes into semi-recumbent position. He is not lying flat. He is coming around 45 degrees, head up, tilt. If he is able to sleep that way, the chances of reflux is less, and keep them on high dose PPI. That's all we need to do. There is no need for an anti-reflux valve stent.
Thank you, sir. Thank you, sir. Excellently answered, sir. In fact, my next question to you was about the anti-reflux stent. Do they actually work? But you have you have thoroughly explained that part also. So I think there are no further questions. We can wind up the session. This has been a very interesting discussion, and we have actually overshot our time by 10 minutes. So if there are no more questions from the chairpersons, I think we can wind up the session now.
Thank you,
And
Bhavnath. In the
thank you so
meantime,
much, sir, for
I
joining us and
thank
taking.
the whole TUGSS team, and I invite you wholeheartedly on behalf of IAGS to come to the World Congress of Endoscopic Surgery, 23rd to 26th of October in the City of Joy, Calcutta. And there we'll be having a separate TUGSS session. In addition, many of you will be part of our faculty in other sessions also. I'm sure it'll be a 4 days of academic extravaganza with a lot of things. I think Subhas Khanna and also our Ramesh Agarwal, they are making a lot of efforts along with our scientific team. Bhavnath is also in the scientific committee trying to put some really very high-end speakers across the world. I think you need to bring the who's who in TUGSS
Looking
also,
forward to it, sir.
just to make sure
Looking
we have a
forward to that, sir.
networking. And Ada, you need to bring some more people from your Istanbul. And I'm sure Anjali, all please speak to personally. You bring your friends. It will be a nice to meet you all in person.
Okay,
Surely, sir.
we will.
Thank you.
Okay. So looking forward to see all of you in Kolkata then. With that, we will end this session now. Thank you so much. Thank you for joining us.
Thank you.
And see you
Thank you
soon.
very much.
Thank you.
Bye.
Thank
Thank
you.
you.